Welcome to this video on the fundamental differences between antibiotics and antivirals. We will explore their distinct mechanisms of action, how resistance emerges, and the evidence-based clinical guidelines for their proper use. We begin with Part 1, Biological Foundations, where we will examine the critical structural and functional differences between prokaryotic bacteria and acellular viruses. This table highlights the core differences. Bacteria are living, single-celled organisms capable of autonomous metabolism and binary fission. Viruses, however, are acellular, obligate intracellular parasites that rely entirely on hijacking host machinery to replicate. In Part 2, we explore antibiotic mechanisms. These agents are designed to selectively target unique bacterial structures, ensuring they destroy pathogens while sparing human host cells. Antibiotics generally function through three primary mechanisms: inhibiting cell wall synthesis, disrupting protein and nucleic acid production, or inhibiting essential metabolic pathways like folate synthesis. Antibiotics are further categorized by their action. Bactericidal drugs directly kill bacteria, making them ideal for severe infections in immunocompromised patients, while bacteriostatic drugs arrest growth, relying on the host's immune system to clear the infection. Part 3 addresses antibiotic resistance, the process by which bacteria adapt to survive exposure to antimicrobial compounds. Bacterial resistance evolves through natural selection in the presence of sublethal concentrations, horizontal gene transfer between bacteria, and the overuse or misuse of antibiotics, which significantly accelerates selection pressure. There are four key mechanisms of resistance: enzymatic inactivation, where bacteria destroy the drug, the use of efflux pumps and porins to expel or block entry, and target site alteration, which prevents the antibiotic from binding. Clinically, resistance often presents as treatment failure. Watch for lack of improvement after 48 to 72 hours, elevated minimum inhibitory concentrations, or recurrent infections shortly after completing a standard course. Antibiotics should be reserved for confirmed or strongly suspected bacterial infections and cases involving severe sepsis. They should never be used for uncomplicated viral infections, as they offer no benefit and drive resistance. Part 4 moves to antiviral pharmacology. Unlike antibiotics, antivirals focus on inhibiting specific stages of the viral replication cycle, while maintaining a low toxicity profile for human host cells. Antivirals target different stages of the viral life cycle, including attachment and entry, uncoding, replication and synthesis, and finally, assembly and release. Each class of drug disrupts these specific processes. Key antiviral classes include nucleoside analogs for chain termination, protease inhibitors that block functional protein production, and inhibitors that prevent viral release or the conversion of viral RNA to cDNA. Finally, in Part 5, we note that antiviral resistance primarily develops due to the high mutation rates inherent in viral replication enzymes, which allows viruses to rapidly adapt to therapeutic intervention. Antiviral resistance is driven by high mutation rates in viral polymerases, which lack proofreading capabilities. Combined with subtherapeutic drug levels and the use of monotherapy, these factors create selective pressure that leads to drug resistance. Clinical indicators of resistance include a viral load rebound after initial suppression, persistent symptoms despite treatment, and the identification of known resistance mutations through genotypic testing. Antiviral medications are indicated for confirmed viral pathogens in high-risk patients. They must be initiated early within the therapeutic window to effectively suppress replication, especially in chronic conditions like HIV or HBV. Timing is critical. Because viral loads often peak within 24 to 48 hours, drugs like oseltamivir or Paxlovid must be started promptly to be effective and reduce the risk of severe complications. We now move to our final section, a comparative summary and a focus on antimicrobial stewardship, emphasizing the importance of informed clinical decision-making. A significant portion of antibiotic prescriptions are unnecessary, often used for self-limiting viral infections. This misuse accelerates resistance, making diagnostic stewardship essential to preserve our current antibiotic arsenal. Effective stewardship requires the right bug, right drug approach. This means confirming pathogens early, using the shortest effective treatment duration, de-escalating therapy when appropriate, and educating patients on the limitations of antibiotics. In summary, antibiotics and antivirals serve distinct roles in modern medicine. By applying strict stewardship and ensuring early diagnosis, we can mitigate resistance and ensure these vital therapies remain effective for future patients. Thank you for watching this overview on managing antimicrobial therapies responsibly.